in the Department of Psychiatry. Oh, yep, we got it. She's a professor in the Department of Psychiatry, but aside from that, does a bunch of, is involved, it seems to be involved in everything. So is sort of directing our psychiatry residency program, co-director of the AIM Center, which many of you have heard, we hear a lot about and are familiar of some of the activities, but gosh, this would be great to get sort of a more concrete sense from this talk about the kind of the interest in the activities, is sort of leading workforce development activities and new initiatives within our department and in the region, and is sort of really a recognized expert in the area of collaborative care, as I think it intersects clinically, training at all levels, and also is a real treat to talk to, is super energetic and kind of creative and just a fun person, probably the best person for us to kind of learn about collaborative care from. And so the objective was, and I'll repeat this and kind of help remind everyone, is that we are thinking about areas that are of particular strategic interest to us, areas that we think that are a little bit underdeveloped, and how we've been approaching at the BRiTE Center the use of technology and exploring several avenues where we think are particularly ripe and inviting, like really good petri dishes to try to innovate and intersect with other very well-established groups. And so collaborative care, beyond just the AIM Center, but particularly within the AIM Center, it's such a robust portfolio of activity and is really part of the strong UW psychiatry identity. And so I feel like many of us sort of know what it is and can read papers about it, but don't have a real concrete sense because some of us have never done it and have never been involved in projects directly where that's happening clinically. And I know that I only learn and retain information that way. And so the invitation was to try to expose us to the model, the principles, the activity, all with an eye towards what might we find those windows of opportunity for doing things technologically speaking. And I will also preface some of what I'm saying right now with the fact that there are probably going to be people from at least 2 or 3 commercial entities that are in one form or another in the digital mental health space or in the telehealth space, doing telehealth for primary care, but that are developing mental health capacities right now. And so as you're talking about these things, please keep that in mind as well, that there are, there's an opportunity to help that science to service gap by also engaging those folks and helping shape their thinking on the topics and on and on. So That's going to be part of our audience as well. So thank you very much for willing to take time to chat with us. We really appreciate it.
Sure. So I'll go ahead and start sharing my screen because I have some slides, if that is good. Hopefully I have permission to do that. I think it's gonna work. It's thinking about it. Okay, and let me put that into presentation mode. If you guys are seeing that, hopefully. There we go. Can you guys see that?
Yes.
Great. All right, so I'm gonna go ahead and dive in. Thank you for that nice introduction. I will just say one additional thing, which is that I finished my residency training here as a psychiatrist at the University of Washington. And then my first job out of residency was serving as a psychiatric consultant for our statewide collaborative care program. And at that time, I did that job basically 70% of the time, which was my full-time job. I had about 10 clinics and between 12 and 15 care managers over that time. So I spent about 5 years really doing this work and starting to think about training in that and implementation, because when you're doing that much of it, you get all kinds of interesting questions coming up. And so as I talk through this, I'll reference kind of the literature and those experiences, but I also just want to say that I'm happy to also talk about what it's like as an actual provider in this space as well. And then the other thing I wanted to just say is I am the co-director of the AIM Center. In that role, I really have had that opportunity to work with lots of other practices and thinking a lot about how they have taken the core principles that I'll talk about around collaborative care and really put them in place in their practice. And I think that'll be interesting to think about when we think about technology and how that might actually help, could actually even help with that implementation process, because I think there, as I'll talk about, there's some unique challenges around thinking about how to do this work out in the real world. So I want to kind of talk about the evidence base. I'll talk about the core principles, and then I want to describe the core phases of an episode of care. And I will do it at those two levels because I think really thinking about those core principles and then the phases of actual clinical work, I think would help us have a framework to think about targets for technology intervention. And I'll sort of come back to that at the end with at least my very superficial thinking about that. I'm really excited to brainstorm with the people on this call around that as well. So I always like to start really at the what I like to think about is the why are we doing this work, and this really started. I think these are the most recent data. They're now getting pretty out of date, so it's probably time for someone to do this again. But this was a big just national sample study, and what they did was call people, and they said, if, in the last year, have you been treated? Do you have a diagnosable mental health condition? If so, where did you get treatment? And the definition of treatment was a single visit with a provider. And I think that these data are really probably still accurate, or actually probably even worse if you think about it these days with so many, we all are hearing about sort of lack of access to mental health care. But in that particular study, what they found is that 60% of the people that had a mental health condition had received no treatment in the last year. Of those that received treatment, about half of that, or 20% of the whole sample, received that care in primary care, and most of that was probably the prescription of a medication, especially depression being the most common mental health disorder. A lot of antidepressant prescriptions. PCPs are the biggest prescribers of those. So, just as a numbers game, that's not surprising. And then about 20% of the sample seeing a mental health provider. Of that, about 11% of the people had seen a psychiatrist. So you really get a sense that, and this is how I like to think about this, is that the opportunity when we think about really trying to think about mental health as like a public health concern is that there's a huge amount of people who are probably not getting access to treatment at all. Some of those patients are probably managing with self-management, but the real window maybe to engage those patients in coming into higher levels of care probably is through primary care, that they're more likely to be able to have access to a primary care provider. And so thinking about primary care is a really important place for both identification and treatment of mental health conditions, really is the framework for why we think about collaborative care. The other thing is that a lot of people think, well, okay, great. If we get all those people into primary care, should we just be referring them out to the mental health system? And I think there's really two big buckets of reasons why that's probably not the solution. The first I sort of broadly categorize as patient factors. And these are really the idea that a lot of patients don't go. So you might give them a beautiful referral, and that might even have access to someone at the other end of that referral. But data out there would show that about the half of the people who are referred to treatment don't really go. Those who actually make it through the door often don't stay. So, an average of 2 visits. Now, of course, some people do. And I think there's lots of interesting things to think about in sort of who makes it and who doesn't. And maybe that's a whole area to think about in terms of technology as well. But that is sort of patient factors. The other thought is really provider factors. And this is really just the huge lack of access that there are, and there just are not enough mental health providers out there in the world. So this paper, which I have a map of the US, what it's really showing is counties throughout the US. And basically this paper looked at the difference between the sort of estimated need in each county and how many providers were actually registered to practice in those counties there. And what you saw is that there is a 1 in 5 counties have an unmet need for non-prescribers. So these are like therapists, mostly master's level people. But 96% of the counties actually had some level of unmet need for prescribers. You can see just kind of globally looking at this that, largely, especially our rural areas are probably disproportionately impacted by this lack of access. And then if you look at certain populations like pediatric populations, this map is a lot worse. So there is just, even if we could get patients to follow through on referrals, and, strengthen that referral system, it's probably not going to be adequate to actually address need. We need some more creative solutions. And that's really, I think, where the idea of how can we expand access to effective treatment in primary care came from. So really thinking about, a continuum of mental health care, that there's going to need to be good coordination across these different transitions of care. The majority of the population is probably going to be, patient self-management or even sort of primary care on their own. Maybe that could be augmented in some ways. But by creating collaborative care and other integrated care models, it really expands that capacity to have kind of a higher level of care even within primary care. And that's what I'll really be describing as I describe this model to you. I think some of the hope was that if you could create some of that capacity, that might also pull some of the burden off of those specialty care behavioral health settings. Really, hopefully, in an ideal world, sort of triaging people to the right level of care to try to help that whole system work more effectively when it is a limited resource. So I'll talk just briefly about sort of the history of collaborative care. And I just think it's helpful to have sort of context about when the evidence base has developed around these models, and then sort of what current research is really looking at. So I think this, the research around recognizing that depression, for example, really was a primary care target, really started in the 80s and 90s. You see interesting literature of like, would a PCP even treat depression? And a lot of like hesitancy actually around that early on. And then, really, I think by the 2000s, sort of recognition that this was an important strategy to address depression, and a whole explosion basically of randomized controlled trials really looking at models and variants of collaborative care, really demonstrating that this is an effective strategy compared to usual care to deliver treatment for mental health and an ever-growing, so specifically depression, and an ever-growing, other diagnoses in primary care settings. And I would say since about 2010, which, is a pretty typical timeline if you look at sort of implementation of evidence-based practice, that it can, take on average 17 years, right? By the 2010s, you're sort of seeing an increased focus on implementation, sustainability, reach, expanded populations. And I think that there's really some interesting things to think about in that space too, which I'll come to at the end around how we might promote collaborative care. So if you want to see more about what this actually is like as a provider, we have this 7-minute video on our AIMS website that really has, it actually was one of my patients, and both he and his family really talk about his experience of being in primary care. You get to hear from his behavioral health care manager and his primary care provider. So I think that can be really helpful if you're trying to kind of immerse yourself in thinking about the clinical experience of this, and really the patient perspective of why this model is helpful for accessing care. So what is this model that I'm talking about? I'll kind of dive into talking about the actual intervention of collaborative care. And I think it's interesting because it isn't like an evidence-based therapy or something. It really is reorganizing the way you deliver care. It's not any new specific treatment. It really is utilizing sort of already established evidence-based treatments for mental health conditions and really organizing the way those are delivered to patients. So this was based on the chronic illness model. And the basic concept is that you take that primary medical provider or primary care provider and the patient and that dyadic relationship, and you basically add 2 additional team members to help take care of the patient and a bunch of practice supports. And I'll kind of walk through those right now. I'll describe the impact study, which is the largest trial to date still, and that was actually conducted by Dr. Unitzer and his work out of the University of Washington. Wayne Caton was also very involved in that original trial, which was published in 2002. And in that trial, essentially what they did is pretty much what most of these randomized controlled trials did. They said, okay, we're going to randomize at the patient level in primary care practices. There were 8 organizations that were involved in this trial. And they basically said every patient that comes in will either get usual care. So that was basically whatever you'd normally do in primary care for patients. You could prescribe medications. You could refer them down the hall to a therapist if that was available. You could send them out for specialty behavioral treatment, whatever you would normally do to address depression, or they received collaborative care. And in the collaborative care arm, what they received is a behavioral health care manager. In this original study, there were both master's level, like social workers, as well as nurses serving in that behavioral health care manager role. And they got a psychiatric consultant. And in general, these were psychiatrists. The psychiatrists, though, didn't function doing direct service. All of their care is actually indirect in this model, meaning that they're available as needed to the medical provider. In some cases, depending on how collaborative care is set up, they might do one session or sort of one visit in person or tele to a patient. But in general, their main function is to actually work with the care manager, do what's called a weekly caseload review, where they'd really look through the entire list of patients that had been identified as needing care and actually prioritize 5 to 8 of those patients to talk about in an hour and provide both diagnostic feedback as well as treatment recommendations. And most of those were communicated through a written note to that primary care provider. Then any medications that were prescribed by that PCP. Any psychotherapy that needed to be delivered to the patient was delivered by that behavioral health care manager. So you really were basically providing patients with access to the full range of evidence-based treatments for depression right there in primary care. This practice was supported by regular use of outcome measures. So really using measurement-based treatment to target to actually identify who wasn't responding to initial treatments and prioritize who needed to be have treatments adjusted. A population registry, so that really is that list of patients, and I'll talk a little bit more about that function later, because that actually was a big use of technology in this original trial, and that a variant of that we still actually license to people today. And then access to effective treatment, again, both therapies and medications, and then having that regular use of the psychiatric consultation. So if you
Anna, are you taking questions in the middle, or should we wait till the end?
I can take questions now.
I mean, I'm not so just a clarifying question. So you said the BH care manager is the one who review. So essentially, it's a data-driven approach. What the BH care manager is mostly is on the back end, looking at bits and pieces that are going to be used to inform the provider's mental health intervention, right? But it's a lot of it is data collection, rather than something, and these are things that are documented in the progress notes. I mean, what's the human piece of it? Is
so
there
the
an
behavioral health
intelligence
care
to this,
manager does two things, and I'll talk a little bit more about this, but they really are care managers, so they are actually facilitating the communication. So in most systems, that's utilizing both a combination of a registry tool and then whatever EMR is used in that system. So and then human interaction. I mean, they might walk down the hall to a PCP too. So that's their kind of care management function. They're working closely with the psychiatric consultant, who again is mostly providing sort of decision making and and sort of really consultation, making sure that you're changing treatment systematically when patients aren't responding to the initial thing that happens. And that measurement, it's basically facilitating good measurement-based treatment to target, which, despite the fact that we know that is important, doesn't usually happen in routine care, in primary care, and honestly, quite frankly, probably not much in specialty care either. I mean, I'll just be really transparent. I think that there's a lot of talk about it, but I don't know if people actually deliver measurement-based care in the way that it was intended to be delivered. Because good measurement-based care means you're assessing, you have a completed measure close to the time you're making treatment decisions. And you're actually using that data to inform your treatment decision, right? Like, has the patient gotten better? Great, let's stay the course. No, then we need to make a change. And I think, and I'll talk a little bit about this, but if you look at trials of antidepressants, like the STAR-D trial is the big trial of antidepressant treatment. If you actually look at what they did, they just did good measurement-based treatment to target, and about 4 changes will get 70% of people better. So I think of collaborative care as really like creating a mechanism to make sure that kind of systematic, good measurement-based care happens, and then treatments can actually be delivered. So that is the other thing that most care managers do, is actually deliver psychotherapy. So, I mean, they are the ones kind of typically delivering, you know, sort of modified protocols for evidence-based psychotherapy. They're often shorter sessions, more like, you know, 30, 45-minute sessions at the max, because they're in primary care. You know, it's not a specialty care setting. Does that answer your question?
Yeah, it does, and kind of the distinguishing between the clinical finesse side of things, clinical finesse with the patient and with the other providers is one side, and the data pieces articulating what are the functions there is very helpful, right? It all has implications for technology. So
yeah. Great. All right, I'll keep going. All right, so I'm going to go back to the presentation mode. I can't see you while I'm doing it, which I don't quite know why, but anyway, I'll figure it out. Okay. So I just want to I want to show you the results. So, you know, we just described sort of collaborative care where we have that infrastructure, that team, and then we have usual care, which again was anything that primary care would normally, they could normally offer. And what you see is when you organize care with collaborative care, the green bars at every single organization that outperformed usual care. And on average, it was about you were twice as more likely as a patient to get better in those clinics that were, you know, if you received collaborative care compared to usual care. And I just think it's notable here that, like, if you look at this, on average, about 20% of the people improved in usual care arm. There were some differences about that. I'm happy to talk about that if you're interested in it. And about 45-50% of the people had improvement if they received collaborative care. I think an important thing to recognize here is that even with this, there are still patients that are going to need more. So this is not a panacea of solving all problems. But if you think about it, if you could get half of the patients that need help better using this approach in your population, that would, you know, reduce significant burden on whatever specialty system you might be referring up to as the next level of care. So that's the sort of piece around stepped care to think about. In addition to improved depression outcomes, there was less physical pain in these patients. This was an older adult population, so that was a big factor. Better functioning, higher quality of life. Both patient and primary care provider satisfaction was measured, and people really liked this model. I think people liked that it was, you know, already leveraged a trusted relationship, that it actually organized care. Sometimes primary care providers are a little resistant at the beginning, but once they have the experience of the support they see this way, they really feel like it's of great benefit to them. And then there were actually data collected in that original impact trial sort of over the next 4 years. People looked at their claims data, and what they saw is that the patients that had received collaborative care had on average about $6 saving, like less healthcare spending than the patients in usual care. So it was a return on investment about $6 for every dollar spent upfront on collaborative care, and that most of those cost savings actually came from avoiding physical health care costs. So like avoiding basically an inpatient hospitalization for a physical health condition. People have gone on, and I talked about this a little bit. There's now actually probably over 100 randomized controlled trials, 80 that are referenced in the Cochrane review, that basically showed that for anxiety and depression, collaborative care is consistently more effective than usual care. Since, you know, sort of the early 2000s, there's been a bunch of other studies and other areas that this has been shown to be helpful: anxiety disorders, PTSD, emerging evidence around alcohol and substance use disorders. And then more recent work, like John Fortney just published their SPIRIT trial, you know, this is effective for treating bipolar disorder and PTSD as well. So this is just a summary of all of those disorders. Also lots of special populations, also comorbidities between depression and physical health conditions. So, you know, what is the secret sauce out of all of these 80 trials? And, you know, I'll kind of talk about that a little bit. Essentially, There are sort of 5 core principles. I've already talked about them a little bit, but I'll just run through them again to sort of define them so you can think about them. This really came from a summit that was held where those authors from all those papers came together and really said, these are the 5 things we think are the active components that really drive the better outcomes. I think there's still opportunities to maybe test some of that more explicitly, but these are the things that all the trials that were effective had these 5 components in common. The first really is that registry tool. This is an example of actually an Excel-based one, just to give you an example of sort of the core features of it. You know, as a clinician, this is super helpful to me. It has the names of all of the patients that have been identified as needing treatment. It has their initial assessment, how recently they've been contacted, and I'll talk about that because engagement seems to be a really important driver. We have some data that early engagement actually probably results in better outcomes for patients. So important thing to be able to quickly have a snapshot view of sort of how long they've been in treatment, and then data around their measures. And these, of course, are not, these are measures that can be used for measurement-based treatment to target. So measures that are responsive to change. So both the PHQ-9 for depression and the GAD-7 for anxiety. People have built registries for other measures as well. And then the other thing that you see here is that we often have registry functions that allow sort of communication or facilitate communication amongst the team members. So for example, you could put flags on certain patients. In this particular registry, there were both flags saying, hey, this is a patient I, as a care manager, want to discuss at our next weekly case review. That makes it easy for the psychiatric consultant, for example, to kind of pre-round and be prepared for those discussions. They could review notes, for example. That you also could track who is a concern for safety, like suicidal ideation. And that's really helpful because one of the things you might do is check in more frequently about those patients, maybe have a lower threshold to be changing or intensifying treatment as part of the suicide prevention sort of protocols in that clinic. The other thing that this really does is make sure you notice who's not coming back. I would say one of the biggest things that I felt clinically that this did that I didn't have in my specialty care clinics was a way to know who I sort of had forgotten about because they fell off of my, return sort of call list. And, I didn't, unless I remembered them sort of spontaneously, I could forget that they were part of my overall caseload. So having that defined caseload and knowing who isn't coming back in so that you can do more proactive outreach, I think is a huge driver of some of the outcomes that we see in collaborative care. I wanted to kind of talk about what an episode of collaborative care looks like now as I dive into the rest of the sort of principles. And I talk about this because I really think of this as it's an episode of care. And I think that's something unique about collaborative care and that people graduate off of this caseload and go back to sort of primary care by PCP by themselves. So there are sort of phases, and I think you could think about technology interventions for each of these phases, sort of how do I identify and engage the right patients and make sure that they sort of get oriented to collaborative care, get brought in. A big function that the team actually does is make sure we have a clear diagnosis that you can then basically apply evidence-based treatment to. So you need a diagnosis to know what treatments are actually evidence-based for that diagnosis. I think that's a step that often gets skipped in primary care. So I call it out really discreetly, even though it doesn't take up a lot of time in the episode of care. It's usually accomplished in sort of the first visit. Although coming back to the diagnosis can often be an important part of follow-up care and treat to target. So if patients aren't getting better, we might circle back through looking at the diagnosis, initiating treatment, again, the full range of treatment in primary care. And then most of the time in the episode of care is really spent in this sort of follow-up care and treat to target. So that's a large part of collaborative care is really using that registry to drive that process. As patients finish, they actually complete treatment. And most of these trials had them complete some kind of summary of treatment as well as sort of like giving patients information about when they might come back into care or might need care, to go seek care again. So this really documents like what was helpful and when would you come back if you needed care. I would say systems level supports are the things like the registry, like regular caseload review that really facilitate this process going well for individual patients. I wanted to show you what that might look like. It's sort of in a snapshot view for an actual patient. This was actually a patient of mine that I saw with a care manager in Seattle. This was actually a college age student. They came in January, kind of at the beginning of the semester. And basically they presented saying, I'm so depressed, I'm not getting out of bed, I'm not going to class, and I'm really worried because my scholarship is at risk if I fail any classes this semester. And the PCP did a good assessment, felt like this really was depression, referred them to the care manager who they basically saw that day. That care manager completed kind of an initial clinical assessment, including collecting PHQ-9 and GAD-7 data, as well as a bipolar screen, a PTSD screen, a substance use disorder screen. So they collected all of those data. This was in a safety net clinic, and so all of our patients were screened for PTSD because there just was such a high prevalence in that clinic. The patient was currently not on any medications. I talked to the care manager sort of within a week. We did that over the phone. The care manager basically reported to me their assessment. I agreed that this looked like a major depressive disorder, plus or minus maybe an anxiety disorder, not clear if it was just anxious features of depression. So we decided to monitor that. The patient's strong preference was to start with therapy as the intervention. I said, that seems reasonable. We should have a low threshold, given that this is a pretty high stake situation, to come back around to look at medications again if the patient isn't getting better. The care manager saw that patient again within 2 weeks. This is pretty typical timeline for early engagement. The initial PHQ-9 score had gone down to a 12 at that time. Patient, I think, was feeling hopeful that she was engaged with treatment. But when the care manager talked to her a couple days later, she said, I think I was more hopeful than, and I don't know if I was actually accurately representing how I'm doing. I'm actually not feeling like I'm doing that well. They didn't do another score at that time, but the care manager called me sort of within the next couple of days. And we talked about that it was likely a good time to revisit medication. And so, this is already the second change in treatment we've done within 3 weeks. That typically is not happening that fast in most behavioral health settings. So, both data driving that as well as the process of care, that proactive nature of that care manager. I basically put a note in saying I'd start fluoxetine. Here's the starting protocol. The patient got started on that medication, came in. You could see that, more accurately, maybe representing her depression symptoms, that score actually going up to 17. And the patient basically saying, yeah, I think I'm going to stop this because it's been a week and I'm not seeing any benefit. And there was a real opportunity for the care manager to say, well, actually, the first week, we just want to make sure you're tolerating this medication. We can actually go up, and we probably should. I will ask your PCP, to reach out to you about that. So care manager not making that change, but facilitating that change happening. The care manager then checking in with that patient a couple of weeks later, the patient saying, I know my PHQ-9 is still high, but I'm feeling a little bit better. I think I'm tolerating the medication. I want to stay on this. And by week 8, actually, there wasn't a PHQ-9, but the patient said she was starting to feel much better, had actually started going back to class. And what you see then is sort of a 6-week gap. The care manager probably reached out during that time, but the patient basically said, I'm busy catching up on school, got her back into the clinic. About 6 weeks later, you could see the patient had a complete remission of her depression symptoms, gone all the way down to a score of a PHQ-9 of 4, was saying that she had actually started doing some of the behavioral activation approaches as well as she was starting to feel better, and that had really resulted in a functional improvement. So I wanted to kind of use this example to give you a sense of what that feels like clinically, and sort of where having even just this, very high level view really helps understand how the infrastructure of collaborative care can really drive rapid changes in treatment, you know, so we basically made 3 changes of treatment within the first 5 weeks of the, or 6 weeks of this patient's care. Typically, you know, people go to a primary care doctor or their regular, you know, a psychiatrist, and they'll be like, okay, we'll see you in a month. And, you know, in that time, all kinds of things may have happened, where that patient may have stopped treatment, or, you know, may not even come back because their depression got worse. But you can see in collaborative care, all of that outreach sort of really proactively doing treatment to target really drives a better care approach. And I just want to, you know, there's now been more real world work looking at this, and sort of this comes out of the Mayo Clinic, basically showing that, you know, when there's a collaborative care program, we actually can drive outcomes of remission response much faster. So 86 days in a collaborative care program in their primary care versus the primary care settings that didn't have collaborative care, where it took almost 2 years for patients to get better. You can imagine that that's a big difference in quality of life. You can also kind of see that, you know, depression is treatable, but it is still the leading cause of disability worldwide, and probably because a lot of people just don't get those systematic changes in treatment. I've talked a lot about the team. I just want to emphasize a little bit, and I'll talk about these things, but these might be interesting to come back to later as you sort of think about how to augment this or support each of these roles. You know, the psychiatric consultant really drives the sort of care from behind the scenes, does a lot. Their main focus is their case review process, but they also do a lot of education of the primary care provider sort of through those notes in clinical practice. Most of their work is done through those case reviews, but often, like, I would, you know, also meet with the primary care providers if they needed help. And then our typical consultation hour, just to give you a sense of some of the other clinical things, over an hour, I would do a brief check-in with the care manager. I'd then really prioritize certain types of patients, any that the care manager was struggling with or the rest of the team was struggling with. I'd really do data-driven. Anyone not improving and who hadn't recently had a change in treatment, we would make sure we talked about them every week. Severity of symptoms, you know, functional impairment, we might talk about them more frequently. People who were dropping out of care, really important target. And then people who were ready to graduate off the caseload, so we would have capacity to take new patients on. I think there's a lot of opportunity to sort of leverage scarce psychiatric resources through this. So if I spent a day doing this, I could typically support about 3 care managers in that time. Each of them might have 50 to 80 patients. So you can imagine I probably couldn't take care of 240 patients a day, a week, every month. But, you know, through leveraging my expertise with care managers, I really could take, you know, support the care of those patients. I also personally did this work from King County, mostly sitting in my office, but I had clinics all over the state. So there is also, I could do this over the phone. I didn't have to be geographically in the same place as the clinic. Just focus, it should be evidence-based treatment. There might be some interesting things to think about on both how do we drive good adjustments in medication treatment, as well as thinking about how might technology help support the delivery of evidence-based therapies. Happy to talk a little bit about that at the end. And, you know, that there's also this sense of like really trying to do this from a patient-centered perspective, making sure that really patients get to have a lot of shared decision-making and sort of what approach they get. And by having that whole range available in primary care, giving more options, there's a lot of data out there that probably patients prefer starting with psychotherapy. And this really offers a model to be able to offer that. The last thing that I'll talk about is sort of what I call accountable care. And this is really accountability to doing high quality care. I think one of the things as I set up clinical practice with clinics, I often really start with, you've got to set good goals. And are your goals around access, about high quality, you know, like outcomes, making sure you have targets and that you're regularly revisiting those. Having ways to measure those quality components of the program is actually a really important part of a strong program. And I'll talk a little bit about that in a slide or two as one of my final slides. And this is one of them. This is an example of sort of data that we would use to drive that accountability. This was one clinic system that had 2 care managers. what you could actually see is because they use this registry tool, we could actually look at a lot of their processes of care and think about that in the context of their outcomes. So this was how many of their patients were actually 50% improved after 10 weeks. That's really sort of our target, and really seeing outcomes similar to what we saw in those trials, right? 49% of the care manager one, 68% of their caseload actually showing that improvement, which are really good numbers. This was like a safety net clinic, really hard to engage population. And, but, you know, I always am interested in variation, and, you know, there's almost a 20-point difference in sort of how many patients are getting better here. And it's always worth paying attention to that. And we asked the question, you know, how is care manager 2 getting these like fantastic outcomes? And what you can see here is that they were actually having more contacts with the patient. And because we could actually look at how they were interacting with patients based on this registry tool, we realized that a lot of that was actually using the phone really effectively. And we could then ask the care manager, how are you doing that? And what she said is basically every time she had a no-show, she would call 3 or 4 of her patients, and she'd usually get one of them, and she'd problem solve with them. Why didn't you come in last time? You know, did you pick up your medications? Are you doing that behavioral activation? And, you know, our hypothesis was that more frequent contact and really being able to intervene, either re-engage or adjust treatment, probably was driving better outcomes. And we then could set up a quality improvement kind of activity by saying, hey, care manager 1, would you be willing to try that? And we would have the data to actually see whether it worked, right? So we could look at this again a month later and see, was that driving up the number of phone visits that care manager 1 was having, for example. I just want to say, and I'm not going to spend a lot of time talking about this because I don't have time, but I'm happy to talk about it more in the future. In the AIM Center, we've really thought a lot about what actually are the phases to actually implement this well. And there are a lot of really interesting things to think about, I think, here in terms of how do you actually help clinics really have good, ideas, like a good clear vision of what they're trying to do to start with, develop that into a workflow, really build the skills for the team to do that. And then how do they do that ongoing monitoring to make sure they're delivering high quality care? And happy to, you know, come back and talk more about this, but just letting you know, we have kind of a really detailed map of how we approach implementing collaborative care now. And I guess I'll just say, you know, it's important to look at those outcomes. One of the things that we actually did is in one of our programs was actually pay for performance. So really seeing that if we drove, initially this was actually a statewide program. And if you look at the blue line, what you're seeing is it was taking about a year for half of the patients to get better. So better than the outcomes in usual care, but not as good as what we saw in trials. What we actually did in this particular case was say, hey, we're going to actually put some of the money that you're receiving to implement this program at risk. We did that in collaboration with the funder, and it was about 25%, and it was for mostly processes of care. You know, are you actually getting people back in? Are you doing your weekly caseload review? And we didn't actually say how you do that better, but the clinics, once they had those clear targets, worked on stuff. And I'll just say from my own experience, many of my care managers like got a better office, got a computer, got somebody to help make, you know, phone calls for their patients to get them back in. And what we saw is a year later, we dropped that time for half of the patients to improve down to 24 weeks, which was much more in line with what we were seeing sort of in trials. So that need to really be monitoring quality and actually adjusting your workflows is really important to driving quality and the outcomes. There are also lots of other data around what helps this go well. And if you're interested in thinking about those, I think all of these, you know, are interesting to think about as potential targets for how we could do those better. And newer studies around clinics that actually sustain care and what they need to have. I'll just say, you know, there's some really interesting things here, like if they're effectively using their IT and their registry, right, they're more likely to actually have to sustain their collaborative care practice. So really interesting thing to think about, potential targets for intervention. And then lastly, there recently has been like a new source of funding, and these are really complicated codes, which I won't explain, but I'd be happy to come back and talk more about. I will just say that they require actually tracking of time over a calendar month to be able to bill for your collaborative care activities. And that to me seems like a really important function or target for potential technology. And part of the reason is that actually capturing revenue for some of the time you're spending in care coordination or caseload review, which are indirect services, really probably helps drive sustainability for practices trying to deliver collaborative care. So I will just kind of say, like, I went through and sort of thought about, like, what are some of the technology things that could be potential targets around, each of these principles. So, our registry function, I'd be happy to talk more about that. Measure collections, identification of people needing more treatment is really important. Shared decision-making and communication among the team members. Thinking about how can you use technology to support medication management or behavioral interventions, and then quality measure monitoring, I feel like are all like rich targets. We could talk more about them. There probably are others in there. And then I also just kind of thought about the axis of sort of episode of care. What are things that, might be helpful? Like, how do we screen? How do we engage people earlier? Should we have text or warm connections facilitated by technology? Establishing a diagnosis, are there ways technology could help with that, right? Could we think about strategies to better initiate treatment, like shared decision-making aids, for example? The follow-up and treat to target, I think there's tons of things there, registry, reminders, quality measures. Our registry actually has a lot of reminders, and that can be really helpful for driving people to do some of the practices that we know result in better care. And then I think there's a lot of really interesting things in thinking about, once we hit it, that relapse prevention, are there tools for self-management? Might we actually be able to schedule check-ins and better identify people earlier who need to come back in for another episode of care? So really interesting targets there, I think, as well. And then lastly, I just, in implementation, I think there's a whole bunch of targets like dashboards to track progression through the phases. How might we use technology to facilitate training, especially maybe, integrated with clinical care? And then I talked a lot about tools to facilitate continuous quality improvement and monitoring quality of the overall program level as well. I've had conversations with technology companies. I listed them here in case you guys were interested in who else is already out there in that space. And I just want to acknowledge all the amazing people I work with in the AIM Center who have done most of the work that I shared with you today. So I will stop there and open it up for questions.
Anna, that was awesome, awesome, awesome. That was a great, great talk. And I think it really sort of brought to life specific opportunities and concrete details of care. That was exactly what we needed. Thank you so much. I've got a kind of an opening question for you that I've been thinking about for a while. Yeah. So the models around primary care are changing a little bit, right? And so sometimes it's a one-shot interaction with a primary care physician. There can be clinics that people rotate the primary care physician, and so they don't really have an established relationship or continuity of care. Yeah. And the last one is some of this is becoming digitized, right? So some of the interactions can be through text messages and can be. So how does that affect? If it affects, in your mind, the potential for collaborative care in these contexts as is, and what are the opportunities there for technology and these evolving models of primary care?
Yeah, I think that's a really interesting question, and one I've thought a tiny bit about, because some of those conversations with people, that I've had that I mentioned, were really some of the companies that are either doing a fully virtual fully virtual primary care, or even doing like almost text-based, right? There's some of these companies that are sort of doing text-based primary care or urgent care. And I think the question there is somebody would have to, I think, own the continuous relationship with the patient. And, in the more brick and mortar models of primary care, I think that has traditionally been the PCP, as the home. I think, could you conceptualize the PCP as a function as opposed to a person, I think is an interesting thing to think about. I think, one of the big things that collaborative care does, it's a little different than traditional primary care, or how a lot of, I think, these models of sort of more virtual care are developing is, virtual care is like, I have an earache, I'm going to call the virtual care doctor or text them, and it's sort of reactive to a symptom, right? And collaborative care is really proactive, right? You're saying, okay, I've identified you now as having depression, and I'm actually not going to leave you alone until we think that's treated. And so somebody would have to own that responsibility. Now, I think a good registry and maybe a pool of people who own that could work. I think it'd be an interesting thing to test. We don't know, right? But I think that that's interesting. We've definitely seen some of the brick and mortar, implementations of collaborative care use shared care managers. So two people sort of sharing the functions of a care manager, often one master's trained delivering psychotherapy and somebody less well trained doing a lot of the care coordination, information gathering, things like that. And if that's coordinated well, it can work well, but it also requires a lot of coordination, because anything you do, I think, to add to the complexity and sort of how you put that team together means you have to have really strong workflows to support that happening. So I think you could have like a rotating PCP, but somebody would have to own that patient. So that could be the care manager. I think you could shift that. Could that be the care manager with sort of a virtual PCP? Really interesting question. I've had some clinics, for example, say that they really, their care manager, they had patients that were comfortable like doing like digital therapy, like doing like a digital therapy program. And so they would sort of triage patients into different levels of even care management. Some, the care manager would be just sort of facilitating them engaging with like a digital, CBT program. But for the patients, and we know this from the data, like there's some patients that just don't want to do digital CBT, right? They could still deliver that. So they, they sort of even like could, and that allowed them to have a slightly bigger caseload, right? Because if you're not actually delivering the therapy to every patient, maybe you see a couple more patients a week because you're not doing therapy that week. So, I think people are kind of thinking about like, what are the tasks and like who could assign them? And that's actually one of our implementation like tools that we have is actually just a list of all the tasks, and I think they just need to be assigned to someone. So I mean, if you conceptualize it sort of that way, I think that's how you could think about, okay, well, what can, say, a virtual primary care, who would own each of those tasks? And I think it'd be interesting to test that. Does that, can you still do that well? In theory, I think yes, but I think you'd have to like look at how do you do that. We wrote a book, and if anybody's interested, I can probably give you a copy, which has like is more for primary care providers for the team, and it has like a list of tasks in that. And I think thinking about it from that perspective is really helpful as you start to think about like, how would it work with virtual? How much of this could be virtual? I think for patients that are going to engage with virtual care, and I think a lot more people are open to that now after the pandemic than they were pre-pandemic. It could be really great because I mean, again, then aren't limited, like the geographic limitations go away. I think a lot of the challenges that people have accessing care, like, I mean, I have a brother-in-law who works for Boeing, and to get into the factory, it takes him about an hour, to get to his workstation. So if he has a primary care appointment in the middle of the day that he has to go to physically, it's like he has to take a half day or a whole day off of work to be able to do it, right? Because it's an hour in, an hour out. If he goes somewhere for an hour, like he's missed a half a day of work to get his like sniffles taken care of, right? Like if we could do that where he could just pop into an office, do that visit, and he could be back at work, like that's a big deal to him and to his company, right? So I think there's a lot of really interesting things to think about in terms of trying to take advantage of virtual. I think the other thing that I think about it is you'd probably need really good way to assess who that isn't enough for and needs a higher level of care. And perhaps that's like, oh, now you need to go to a brick and mortar person or have one PCP, or, maybe there's another stop before going on to specialty care. That would be another way to conceptualize it. Like maybe it's another layer in that sort of continuum of care. Those are ideas.
Thanks, that's all helpful. Let's open it up for others in the last couple of minutes.
Following up on that, I was curious to ask more about the role of the care manager in providing interventions and sort of at what point. I noticed in kind of the example case you gave, there's a couple of contacts with the care manager speaking with the client or the patient. So kind of wondering what's the most kind of typical engagement between the care manager and a patient? And at what point, might they do kind of like a short course of behavioral activation? At what point might they say, oh, actually, we want to refer this person to 12 sessions with a counselor who's either co-located in our clinic or maybe refer? And that may just be too much of a case-by-case question, but I'm curious if you could kind of flesh out that role a little bit more.
I can talk about it, and I can say I think there's some interesting questions in there too.
Okay.
So it's probably a both and. In general, most of the care managers, when we train clinics, we say the care manager should have a basic, repertoire of being able to deliver like primary care protocol of CBT of some kind. Increasingly, we teach BA just because we find that it's really working across kind of a range of diagnosis, whereas PST tends to be, which was what was used in the original impact